Honoured to present at the World Congress on behalf of the Swallowing Research Lab at the University of Auckland. Accumulated secretions in the pharynx are associated with swallowing difficulties, aspiration and pneumonia, as well as increased length of hospitalisation. There are a number of validated tools available to rate accumulated pharyngeal secretions. They rely on clinical judgement, and therefore an understanding of normal levels of secretion present in a healthy pharynx is really important in order to critically assess abnormal accumulation versus normal variance. The New Zealand Secretion Scale is a clinically meaningful tool for rating aspects of secretion severity. The amount and location of secretions may reflect the severity of the motor dysfunction and present as a risk of progressing secretions into the lower airways. However, uniquely to the NZSS is the response to secretions, which perhaps relates more to sensory integrity and represents another factor impacting on airway protection. The New Zealand Secretion Scale is a 7-point scale with higher weighting for response in comparison to location and amount. The New Zealand Secretion Scale has strong inter-rater reliability in both experts as well as clinicians and students. And in validity testing, it correlates with both penetration aspiration, and we wanted to add to the validity of the NZSS by building the understanding of normal levels of secretion. In our laryngology clinic, we rated the NZSS of consecutive referrals who received an endoscopic evaluation for voice complaints, dysphagia complaints, and other laryngology complaints, including globus, chronic cough, and reflux. Patients ranged in age from 8 to 98 years old, and all patients had an NZSS as well as a voice handicap index and an eating assessment 10 tool. NZSS scores were low for both voice and other laryngology complaints, with a median of 1 out of the maximum 7. And NZSS scores were elevated for those with dysphagia complaints, with a median of 4. Interestingly, one patient referred for chronic cough had a slightly elevated NZSS of 3 out of a maximum 7. This patient was subsequently diagnosed with a vocal fold paresis and mild swallowing impairments for thin fluids. 6 patients with voice complaints had elevated NZSS, of whom 4 were subsequently diagnosed with swallowing difficulties, and 2 had significant acute respiratory infections. The pharynx needs to be moist for vocalization and swallowing. In these images, you can see a range of normal lubrication variance in laryngology referrals without dysphagia. All patients were scored 1 on the NZSS. The range of secretion accumulation in laryngology referrals with dysphagia was much more varied, with elevated NZSS for many. In these 4 pictures, you can see a patient with head and neck cancer in the middle of chemoradiation treatment with a NZSS of 7. B, a patient with Parkinson's disease with accumulated secretions that cleared as the patient swallowed more of the trials, with an NZSS of 4. C, a patient with the traumatic brain injury 6 months post-injury and an NZSS of 3. And D, another patient with Parkinson's disease, again with an NZSS score of 4. It's interesting to note the difference in secretion accumulation in patients with head and neck cancer from early treatment, where secretions were loose and copious with NZS scores over 4, to later stages where secretions were sticky but reduced in quantity with NZS scores of 1 to 4. Lower volume secretions were still considered troublesome by patients in this group, and emphasized the need for clinical correlation and consideration of other factors aside from absolute volume measures in managing secretions. It reinforces the clinical importance of accurate and descriptive secretion reporting to guide multidisciplinary management of patients. This new data adds to the validity of the NZSS for measuring pathogenic secretion accumulation. Consistent, standardized reporting of secretions is important and very easy to achieve in a clinical environment. These findings suggest that all laryngology referrals with elevated NZSS should be screened for swallowing difficulties. Monitoring of NZSS over time is useful to assess response from treatments and to look at patient progress. Targeted secretion accumulation treatment approaches are lacking at this time and are greatly needed and should be the attention of research in the future. Thank you very much.
Thank you. Yep. Wait a moment. Any comments or questions so far? Okay, so what I'd like to ask is, so what do you think about extremely dry condition due to the post-chemoradiotherapy? Because these patients may, NZSS score shows mild, although the dysphagia severity is may severe. What do you think? Yes, I mean, extremely dry conditions.
Absolutely, thank you. I appreciate that question, and I did forget to say at the beginning that I have no disclosures, and nor do any of the authors in this presentation. I think you're absolutely right, and exactly why we always need patient reported outcome measures alongside any evaluation, whether it's instrumental or a bedside evaluation. We need to know what the patient thinks first and how bothersome any part of their dysphagia is. And you're quite right, the NZSS was originally created for acute care where accumulated secretions are of risk to the larynx. And the head and neck population definitely sits in a very different position with regards to sticky secretions. I don't know whether it means we need a second NZSS just for head and neck cancer patients because the secretions are so unique for them or not. But at the moment, we're working with a group in India to collect NZSS scores on a large cohort of patients with head and neck cancer to truly unravel that situation. So thank you.
Yeah, that's great research. Thank you. So any other comments or questions so far? Yeah. Any other comments for audience, Dr. Anna? So I've learned from your literature. So the secretion score is available for tracheal problems. Is that right? Tracheostomy patients.
Yep.
for example?
Yeah, absolutely. Many of the patients in the original validity study were tracheostomized. And since then, we've further evaluated it in groups of cardiothoracic patients and lung transplant patients, as well as spinal surgery patients. So, as I say, it's certainly had most of its work within the ICU and high dependency unit acute care sections of our dysphagia populations. I know that the Royal College of Speech Language Therapists in the UK has used it as their preferred tool for fees in COVID patients. So most definitely tracheostomy patients are in that group who it fits for.
Yep, very interesting. All right, thank you. Thank you again. Yep.
Thank you.
Bye. Okay, so in the last presentation will be made by Dr. Zhang Jana from Germany. Your presentation is entitled Flexible Endoscopic Evaluation of Swallowing in Children with Spinal Muscular Atrophy Type 1. You may begin now.
Thank you, and good morning from Germany. You can start my presentation now.
On behalf of my colleagues and myself, I would like to thank for the opportunity to present our results on flexible endoscopic evaluation of swallowing in children with spinal muscular atrophy type 1. This study is part of the project Dysphagia in Children with Rare Diseases. It is carried out as a research collaboration between members of the University Dysphagia Center and the Department of Pediatrics. We would like to thank the entire team of the Department of Voice, Speech and Hearing Disorders for their support. Dysphagia is an early and common symptom in children with SMA type 1. If untreated, the rare autosomal recessive neuromuscular disease leads to death within the first 2 years of life. The clinical picture of swallowing disorders and results from video fluoroscopic swallowing studies in treated and untreated cohorts have recently been published. Common problems are poor secretion management, fatigue during nursing session and weak sucking, insufficient upper esophageal sphincter opening, post-swallow residue, and inadequate airway protection. New therapies show a beneficial effect on survival and motor skills. However, there has not yet been an improvement in bulbar function. So far, no data on flexible endoscopic assessment of swallowing in this population have been published. The following is a prospective pilot study including children with SMA type 1 that received treatment with onasemogene abipavovec, short Avexis 101. This is applied as a single-dose intravenous injection and approved in Germany in 2020 with no age or weight restrictions. It works by providing a new copy of the gene that produces a human SMN protein that is necessary for survival of motor neurons. Pre-post fees was planned, parents' informed consent was given. 2 children were included retrospectively. We aim to set up a fees protocol for children with SMA type 1, to investigate findings concerning swallowing safety and secretion management and their expression in a score, and finally to find out about changes in swallowing through gene replacement therapy. FEAS was performed by specialists in phoniatrics and ENT at our University Dysphagia Center using a 2.6 mm video scope. Suction was always kept ready. Nasal decongestion and topical anesthesia were routinely applied. Some children had problems with an upright posture, so they were examined while lying in the stroller or on the caregiver's arm. We tried to calm the children with a pacifier and glucose solution or to distract them with interesting toys. The boluses administered were age-appropriate, mostly formula, water or puree, and all boluses were colored green. The implementation was based on the standard FEAS protocol by Langmuir and adaptations by Miller, Schröder and Wilging. Murray's secretion rating scale, a scale on premature spillage, initiation of the swallowing reflex, Rosenberg's penetration aspiration scale, Yale pharyngeal residue severity rating scale, and the laryngeal sensation scale were used. None of these are validated for pediatric FEAS. The sample consisted of 4 female and 4 male children with SMA type 1. Mean age at diagnosis was 3 months. 4 children had already been treated with nusinersen in advance. This is a 4-monthly intrathecal injection that increases SMN protein levels, which is beneficial for survival and motor function. Finally, all children received Avexis 101 at a median age of 8 months, with a clear outlier age 55 months. Median age at first swallowing examination was 9 months. The post-examinations took place 4 to 6 months after gene replacement therapy. Half of the children were tube-fed, half were and still are fully orally fed today. All but 1 child showed an improvement in motor function in the job intent. In comparison, no increase could be seen in the nutritional stages, which was recorded with the neuromuscular disease swallowing status scale at the same time. A total of 13 fees could be carried out in the pilot phase. Pre-post fees could be completed for 3 children. Additionally, there was a baseline measurement for 1 child and a follow-up for another child. The average duration of fees was less than 5 minutes. Interestingly, in children who did not swallow, the epiglottis appeared sometimes large, flat, and not very mobile, which goes well with the muscular weakness. At first, there were 4 children who could not swallow. After gene replacement therapy, 1 child started to swallow. The video shows that it is hard work and far away from a normal swallow, but the child is able to drink and eat small portions, and up to now, no infections or pneumonia occurred. Murray's secretion scale could be recorded in all FEES studies. Pharyngeal secretion pooling occurred in 7 children. At post-measurement, 3 children showed a slight improvement, which interestingly could not be found in the additional follow-up examination of the first child. All parents reported that the children had to be suctioned less frequently after Avexis 101 administration. Due to a lack of bolus transport to the pharynx, spillage could not be scored in 2 children. They were fed exclusively by tube, kept the bolus in the anterior oral cavity and spat it out. Here too, there was a slight improvement in the post-examination in 1 child, which could not longer be found in the additional follow-up. Penetration and aspiration could only be captured for those children who transported material into the pharynx. Silent aspiration of liquid or puree was seen in 3 children. 1 child had an improvement that worsened again, and 1 child who could not swallow at baseline and pre-examination was able to swallow at the post-exam and had an improvement in PAS. On the right hand you can see some snapshots of penetration and aspiration, and if narrowband imaging is on, the green-colored bolus appears in red. Post-swallow residue were present in all children with the ability to swallow. They ranged from trace to severe in the vallicular and the piriform sinus. Laryngeal sensation was reduced in all children, and due to a constant screaming and weak muscle strength, a clear result of the touch method could not be determined in every examination because the reactions could not be clearly interpreted. In the video you can see a feeding tube that is constantly penetrating the epiglottis. How would you score the reaction? Poor secretion management, delayed or absent swallowing reflex, premature spillage, penetration, aspiration, and post-swallow residue, as well as reduced laryngeal sensation, are common problems in children with SMA type 1. FEES is a safe procedure for this group and especially suitable for the interpretation of the secretion management. The general transfer scales that were developed for adults must be carefully reconsidered and in the future adjusted based on significantly more data. No clear improvement in swallowing through gene replacement therapy could be determined in this pilot study, despite an improvement in motor function. A trend towards improved secretion management can be assumed. Please consider we need a lot more data for a significant interpretation, including regular follow-up. There will soon be a newborn screening for SMA in Germany, so that the treatment can be started much earlier, which will hopefully lead to better swallowing effects.
Okay, thank you for your informative presentation. The floor and chat box are now open for discussion. Any questions or comments? Yep, Dr. Matsuro, please ask.
Thank you for a nice presentation. I'm Hirotaka Matsura from Japan. I'm just curious whether children, so basically children don't accept the endoscopic exam, so pain or any or some. So in this sense, video fluoroscopic exam also can be used for. What do you think of that?
Yes, thank you for your question. That's right. We have the feeling that if you use nasal decongestion and lidocaine for topical anesthesia and really thin endoscope, then there's not really a pain for the children and the examination goes well. But on video fluoroscopic studies, you can see some other parts, and on the fees, you can see some parts you can't see there. And for those children, it's really interesting to see the secretion management, because that is a big problem for them. You have to provide suction like 40 times a day, and in some children, and we wanted to see what happens there. And this is a point why we wanted to test fees in those children to see what happens with this foamy secretion.
So, in your, at least in your experiment, the children does accept the exam, and you think highly of saliva management, or so you use endoscopic exam. Is that right?
Yes, I won't say that they really like the examination. So you often see them cry in the beginning, and we saw from some studies, if they are younger than a year, we try a pacifier and glucose solution, or we really try to distract them with toys, with light and some music. And this is really helpful and interesting. And so we do not really have the choice. Video fluoroscopic study is not that widespread in Germany. It might be an interesting, study for the future, but in our clinic we use fees, and we are really experienced in fees, and so we wanted to see what we can find in those children in fees. There are some other studies now in children with SMA type 1, like Kathleen McGrattan presented something, and there's some smaller studies going on, and I think this population will be as well with video fluoroscopic studies as with fees. There will be some more publications in the following
Thank
months.
you very much.
Thank you.
Thank you again, Dr. Dan Jenner. Unfortunately, we have no time. So I'd like to thank everyone for taking part in this session. And with that, I'd like to close this session. Thank you for attending. Bye. Bye.